health are very, very interrelated, and you might not think this at first. But we know that being malnourished can affect your clinical outcomes. First of all, your diaphragm is a muscle. So if someone is malnourished, their muscles and muscle function typically suffer. So if someone is malnourished, the function of that diaphragm suffers because of being malnourished. So the respiratory muscles their function will be decreased during times or issues of decreased intake. One of the big kind of jobs or duties of the lungs is it helps with immune function. The lungs contain little hair-like projections called cilia, and their job is to push out harmful things that you breathe in. So the immune function of the lungs are depressed when someone's malnourished. Or malnourished, our immune function overall is depressed. So it's certainly going to affect the lung system to fight off infection. We also know that the lung parenchyma, and parenchyma means the very essential portions of the lung, or the essential portions of that organ. So when we talk about the parenchyma of the lungs, we're talking about the bronchioles, we're talking about the alveoli sacs, we're talking about the capillaries. Those very basic structure of the lungs are going to be reduced. Their function is reduced because a person is malnourished. Why are those functions reduced? Because they're not getting adequate nourishment. Like when someone's malnourished, the whole function of the lungs, the alveoli is necessary for exchanging oxygen to CO2. It's not going to function as well when someone's malnourished. So they're not getting the nutrients they need. Adversely, when someone has a lung condition or a lung issue, it further complicates intake. What do I mean by that? If you have a condition like COPD, which hopefully you know a little bit about, but we'll talk more about, it affects your ability to eat adequately. Number one, you have early satiety, so you feel full. Number two, have you ever been sick and unable to breathe just with a sinus infection? Do you feel like eating? No. So oftentimes, lung conditions will also decrease intake. So we know that being malnourished decreases lung function, but also having a lung condition decreases your ability to consume adequate nutrition. Kind of working with this like catch-22 here. There's a thought that taking antioxidants will improve lung function. Antioxidants, think about it. Whenever there's oxidative stress, the antioxidant's job is to reduce the oxidative stress. Okay, so when we're breathing in things that are harmful or things that are in the air, that causes oxidative stress within our lungs. The antioxidants are thought to reduce that oxidative stress. So in theory, taking extra antioxidants seems to improve lung function. The problem with it is that there's not a lot of research to actually support the improvement. It seems to make sense in theory, but when we actually try to look at it in research, it's hard to kind of prove that effect. We've kind of touched on this, but when someone has a respiratory disease, it affects their intake. So it causes the early satiety, where they feel full very quickly. It causes anorexia, which is the overall just having a poor appetite. It can lead to weight loss. They often are coughing, okay? So that impacts or interrupts their normal ability to consume nutrition. And they have dyspnea. It's a hard word to say, but that means shortness of breath. Specific and look at a couple of conditions related to the pulmonary system. The first one I'm sure you've probably all heard of is asthma. And asthma is simply a problem where there's inflammation and constriction of the bronchial tubes. If you look at that picture on the left, you see the asthmatic bronchiole, and you'll see that number one is you see the edema in there, and then there's airflow obstruction. So when someone's undergoing an asthma attack, it's very difficult for oxygen to flow through the bronchioles. So this is why they're having that shortness of breath. There's this edema, and there's this obstruction within those bronchial tubes. Because of this, you probably have, if you have asthma or seen someone with it, there's a wheezing, there's a breathlessness, their chest is kind of tight because they're trying to pull the oxygen through those bronchioles, and there's coughing. They constrict. Potentially, but they would have so many symptoms before then, I don't know that it would be instant. You know what I mean? Like it would probably constrict slower, so they would probably feel some sort of symptoms before it completely inhaler, yes. So we usually see that there's some sort of airflow obstruction in these patients or in this condition. There are two main types, okay? We have what's called allergic and we have non-allergic, okay? So our allergic asthma is usually triggered by some inhaled allergen. Okay, and then that picture just kind of shows you potential like allergens, whether it's like mold or dust mites or certain trees or certain flowers that will kind of elicit that allergic asthmatic response. So when their lungs come in contact with these allergens, it causes that constriction of the bronchial tubes, and then it's difficult for air to flow through it. We have the non-allergic type that can be caused by other things. So we see the non-allergic type, some people experience it when they are very anxious or in a stressful situation. Some people have what's called exercise-induced asthma, so when they're participating in some sort of strenuous activity. Some people have cold air or dry air related asthma, hyperventilation, smoke, viruses, and other irritants. Okay, so that would be the non-allergic type. People that have the allergic type of asthma typically also have very severe food allergies. That's significant, and I want you to understand that. It's because of the IgE, the immunoglobulin E response, that causes both of these conditions. It is not because the food allergy causes the asthma. It's not that. It's because both of these responses are caused by that IgE immunoglobulin. Does that make sense? I'm going to say it again just in case. So severe food allergies are caused by kind of a response or an activation of the IgE immunoglobulin. Allergic asthma is also caused by an activation of the IgE immunoglobulin. So I'm not saying in every case that severe food allergies causes allergic asthma. I'm saying that the IgE immunoglobulin response is what causes both. Does that make sense? So what do we do? What do we do if someone has asthma? Well, I skipped ahead of myself, but I think we touched on this. So when asthma occurs, the bronchi, the bronchioles are going to respond either to that allergic stimuli or the non-allergic stimuli, okay? This causes the tubes to constrict, close up. There's inflammation and edema within that tube. There's also an increase in mucus, okay? So with that constriction, plus that mucus in there, makes it very difficult for the oxygen to flow through the bronchioles. Things that we see the cough. Asthmatic patients typically have kind of a dry cough. The dyspnea, which is the shortness of breath, and the tight feeling in their chest. Other things that they may experience an increase in respiratory rate, and that makes sense, right? Because you can't breathe, what happens? Start to get a little anxious, your respiratory rate might begin to increase, your heart rate increases, your breathing becomes labored. That means it takes extra work to breathe. And then you may end up with hypoxia. And hypoxia means a decrease in oxygen content in the blood. Because you're not able to take breaths. So what do? Paula mentioned this is when you usually take the inhaler, right? But what's in that inhaler? What is it? It's a bronchodilator. So if your bronchioles are constricting, a bronchodilator is going to do what? It's going to dilate or open up those bronchioles so that you can get airflow through. So in acute episodes, we're going to give some sort of bronchodilator to quickly open up the bronchioles. For chronic or long-term control, we usually give some sort of steroid therapy. If you know anything about steroids reduce inflammation. Okay, so that's why we would give it. It reduces inflammation. And we want to talk about environmental control. So that means if we know that there are certain things that people are allergic to, removing those from the environment as much as possible. And controlled breathing techniques. What's the first thing you do if you can't breathe? You're anxious, you're trying to breathe faster. Sometimes just teaching patients when they're in kind of having an attack, how to remain calm and breathe appropriately will help with decreasing the length of that asthmatic episode. Nutritionally, there's a couple of things that we just want to be aware of. So there seems to be a link between asthma and obesity. We really don't know the etiology or why that there is a link. There are a couple different theories. Perhaps asthma is associated with just the increased weight that the person's carrying. Perhaps the genes that code for obesity also code for asthma. We don't know, but we know that there appears to be a link. As someone becomes obese, their risk of developing or having asthma appears to increase. Just don't know exactly why. We also know that when there are leukotrienes in the body, they elicit.
Sorry. So the order there was the obesity first for asthma or asthmatic to become obese or both?
They just indicate there's a link.
You're just piling them
Yes.
together, links, you don't know
Which one comes first or second? Leukotrienes are found in the body and they tend to increase inflammation. Okay? We know that one of the symptoms or one of the things you see with asthma is that there's inflammation within the bronchial tubes. So oftentimes what we'll do is we'll tell patients to increase the omega-3 fatty acids in their diet, and this seems to reduce the leukotriene production, thereby reducing the inflammation. Again, something that potentially works in theory. So that's why it says on the last bullet point to supplement with the omega-3 fatty acids. And then you see it says potentially supplementing with the vitamin C. And again, vitamin C is what? What is that? Antioxidant. So the thought again is that the antioxidant will reduce some of the oxidative stress on the lungs. Zinc seems to support lung function. So all of these are potential things that you could supplement to kind of improve or maybe reduce the effects of someone who has asthma. There's also a little note, if you're looking at my note, that says breastfeeding studies are kind of inconclusive, but there's another thought that children that are breastfed are at a decreased risk of developing asthma as well. But again, the studies are inconclusive. Huh? To develop asthma? Yes. And again, so this is where you may see that as someone gains more weight, they may become asthmatic, or maybe just like a exercise-induced asthma. I've seen people develop as they get older. Some of those you see. Maybe not so much the allergic type, because they probably have had that most of their life, but some of the others you may see them develop later on. Usually if it happens, then you probably want to get it checked out. So if it happens once, you probably want to get it checked out. Especially if you want to continue exercise. It's always best to just, if there's a possibility of it, it's just best to have the inhaler just in case.
So just like you can kind of, you say grow out food allergies, or you do the same thing with asthma, and it becomes like less of a problem as you go on in your life?
So I would have to say yes, and this is not a scientific reason why I'm saying yes, it's a personal reason why I'm saying yes. So I know for my son, he has allergic to asthma, and the thought is that as he gets older, it will not be as much of a problem for him as he gets older. The other thing that a lot of allergists will do, they will give them allergy shots. So in the allergy shots, they're actually giving them doses of what they're allergic to, build up their tolerance so that they no longer have ongoing issues with asthma. You know what I mean? Like they build up their tolerance. And I also noticed that you can grow into allergies too. It's kind of crazy. You can grow out of them, but you can grow into them too. Other questions? Okay. Got a lot of nutrition stuff about it, right? One more thing. So additional therapies, just removing the environmental triggers. There are some medications that may like reduce some of the side effects, but they have other issues. And one that's particularly mentioned is your steroids. Your steroids are known to increase glucose levels. So we want to be careful on someone that is potentially diabetic, because we'll see that they typically increase their glucose levels. They also cause issues with sodium retention. Wherever sodium is retained, water is retained, so it can cause issues with swelling or edema, and that it decreases bone mineral density, which we'll kind of touch on when we talk about musculoskeletal, that can increase the risk for osteoporosis. Those are things we want to remember.
So why does steroids increase glucose?
I do not know the mechanism right off the top of my head. Why do steroids increase glucose levels? I would have to look at the actual mechanism.
They're like,
Oh.
they're covered the adrenals, so they are part of the light response. So to get away, like you need more energy.
I would have to look at it a little bit more. But you'll see that across the board. Steroids are always going to increase your glucose. Other questions? Okay, and then so,
Sorry, it's kind of backtracking a little
Sure.
bit, but with the severe food allergies, is that what is just the allergic type or both types?
the food allergies, mostly in the allergic type.
Okay.
Because remember, it's the IgE that's going to cause both.
Okay, got it.
And then the last bullet point, your diet should be nutritionally adequate. So that's just meaning if someone is obese, then we do want to promote gradual weight loss closer to a normal body weight. Okay, so again, this is just our NCP process, just reminding some of the things that we should look for. Some of these terms we haven't talked about yet, like under physical assessment, cyanosis, and wheezing. Well, wheezing, you guys know what that means, but cyanosis, we haven't talked about that. We're going to touch on that in the next section. And then for biochemical data, it looks at the levels of O2 and CO2 in the blood, which are going to be determinants of lung function. It also looks at glucose levels, right? We talked about why glucose levels may be important, particularly if these patients are on steroid therapy. The diagnosis in this section, I'll be honest, I don't like these diagnoses because you could use the overweight one, but it's really not related specifically to asthma. You get what I'm saying? It could be overweight, but that's not really related specifically to asthma. So I don't really like the choice we have listed here, or I have listed. But we will practice with you guys. Interventions for these patients include diet modification, so reducing weight if they're overweight, and then just the vitamin supplementation with the omega-3 fatty acids, the zinc, and the vitamin C to help with lung function. So overall, when we're looking at someone that has asthma, it doesn't necessarily increase their calories or protein needs. Those things are normal. It may decrease their needs slightly if someone's overweight, just to get them closer to a normal body weight. But this isn't going to have like a direct impact on their overall needs. So if we're estimating needs for someone with asthma, their needs are typically what you would do normally for that. Okay. I'm going to move on to COPD. I'm going to spend a little bit of time on this section. So when we think of COPD, it stands for chronic obstructive pulmonary disease or disorder. There are two major, types are the best way to say it. And with both types, there's a limit in airflow. So airflow is limited, okay? The first type is caused by inflammation of the bronchial tubes, and we call this bronchitis. This is not your upper respiratory bronchitis. This is more of an ongoing issue with bronchitis. Because if you've ever been sick and had an upper respiratory infection, they may have said you have bronchitis. But this sort of bronchitis, typically COP isn't diagnosed till you have bronchitis like 2 or 3 years in a row. And it's usually related to more than just an upper respiratory tract infection. Okay, but we still see that big inflammation within the bronchial tubes. The second type, or later complication of COPD, is called emphysema. And with emphysema, there's actual destruction of the lung tissue. So there's destruction of the alveoli. If you listen to the recording, Professor Scott probably does a really good job of going over the risk factors. And she's kind of goes over that smoking and secondhand smoke are two of the major risk factors for COPD. Others include air pollution. There seems to be some link between certain childhood infections and occupational exposure to certain pollutants. And the last one, the low body weight, I want to explain that, okay? So it doesn't mean that if you're very thin, you're going to develop COPD. But again, there seems to be a link where as people kind of lose body weight or become malnourished, their risk of developing COPD increases. So it's related to the malnourishment, not being a lean individual overall. So with smoking and secondhand smoke, whenever that's taken into the lungs, it elicits this inflammatory response because it's not supposed to be there. And this is what causes the bronchitis, and ongoing could turn into emphysema. Okay, so with we're going to kind of go back and forth between talking about the bronchitis and the emphysema, okay? So we're going to start off looking at the bronchitis. So we want to make sure you understand it's inflammation and scarring of the bronchial tubes, okay? Because of that inflammation, there's a restriction in airflow. There's an excessive mucus production. So very similar to some of the things that we saw with asthma, but this is an ongoing issue, okay? It's characterized by kind of like a persistent cough. Your father had COPD? Okay. Gotcha. Yeah.
Like, he tries to do two steps and has to stop and cough like 10 times with that. And then this time.
Right.
And that's why it's because he starts coughing and up.
Exactly. So we see some of the same symptoms that we do with asthma, but instead of like asthma having attacks, like they come and go, this inflammation and this scarring of the bronchioles is ongoing, so it doesn't go away. Okay. So when you think of the bronchitis, think of the inflammation and scarring of the bronchial tube, and think of excessive mucus production. With emphysema, what we have is that over time, exposure to the pollutant, exposure to the smoke, causes inflammation of the actual lung tissue. So here we see that the alveoli, or the actual lung tissue, becomes damaged. So if you think of what alveoli do, they're the place where gas exchange occurs in the lungs. So if there's destruction of the actual lung tissue, we now have decreased surface area for that exchange to occur. Okay? So with bronchitis, you just have the inflammation and scarring. But with emphysema, you actually have the loss or destruction of the lung tissue. So this is kind of like a late complication. And in the photo, you can kind of see the difference between the alveoli that's considered normal and that has emphysema. Okay. Flipping back to some of the things we see with bronchitis. Okay, so we talked about the generalized inflammatory response, and you have hyperplasia of the mucus secreting cells. Hyperplasia means that there's an increase in the production of mucus secreting cells. So this mucus further thickens the walls within the bronchial tubes. They're swollen, there's excess mucus, makes it really difficult for the air to get through. The other thing, remember I had said you had the cilia in the lungs? And their job, when pollutants come in, they push them out of the lungs, okay? Hair-like projections that push out the pollutants. How well do you think they're able to function if the walls are covered with mucus? Can they push out the pollutants? No. So if you look at that last bullet point on there, the thickened mucus creates this environment where bacteria can grow. Because now the cilia can't do their job and push out the things that are bad. So when people have COPD, it's often common that they develop other respiratory infections. Because now there's like this breeding ground because we can't push out the things that are bad. So when a person has COPD, what do we see? What are their signs and symptoms? So we'll see decreased airflow rates. And this makes sense, right? It's not rocket science, right? If there's inflammation and there's mucus, air doesn't flow through as well. So there's a decrease in airflow rates. There's the dyspnea, which is the most difficult word to say for me, I don't know why, shortness of breath. Okay? Hypoxemia means that there's a reduced oxygen content in the blood and in the tissues. Because of hypoxemia, because there's reduced oxygen, we see three things. We see the cyanosis, which is the bluish tint to the nails. If you look at the top picture of the nails and the toes, you see kind of a bluish tint to the nails. That's what cyanosis is, and that's because of the reduced oxygen levels. And the last picture, you see the clubbing, or the bottom picture, you see the clubbing. Again, that results as well from the reduced oxygen content. And then the third one is secondary polycythemia. Polycythemia is an increase in red blood cells. What do red blood cells carry? Oxygen. So whenever there's hypoxemia, or there's lower amounts of oxygen in the blood, the body is really smart. It produces extra red blood cells to try and compensate and carry more oxygen. So that's why it's called secondary polycythemia. There's an increase in the production of red blood cells to try to improve the hypoxemia. Hypercapnia, this refers to CO2 levels. So the CO2 levels in the blood are going to increase. Cor pulmonale occurs as the disease progresses, and this is heart failure on the right side. And this is because it's working so hard. Okay? The heart is a muscle. When a muscle works hard, what happens? It's bigger, right? So it's working so hard. It's getting bigger, trying to pump the blood and oxygen through the body. So eventually, it kind of coops out. And then, of course, we see malnutrition, just as Paula explained, for the reasons that she talked about. Then it becomes difficult to consume adequate nutrition because of the coughing, because it's difficult to have a difficult time breathing.
Some people feeling like numbness in their hands and feet, they're not getting like if we see like a cyanosis on the toe, is that something that happens?
Yeah. It's not listed here, but I would think that if there's reduced oxygen content, they're going to begin to feel that. If it's not, like hopefully they're on some sort of ongoing therapy to correct it from getting too bad. But potentially, yes, they can feel that. Okay, so with emphysema, kind of going back and forth from what I told you. So with emphysema, we said that this was a late complication of COPD, right? So with this one, the bronchioles lose their elasticity, they collapse, and they trap air in the lungs. Remember, we said that the alveoli is kind of where that air exchange occurs. Well, when those tissues kind of lose their elasticity, some of that air gets trapped in the lungs. Some of the CO2 that should be exhaled gets trapped in the lungs. So with emphysema, we see what's called a decreased forced expiratory volume. Your forced expiratory volume is the volume of air that you exhale out. So if there's destruction of the lung tissue and things lose their elasticity and CO2 gets trapped in the lungs, that forced expiratory volume does what? It's going to decrease. Some of that air is trapped in the lungs. These patients also experience the dyspnea, which is a shortness of breath, orthopnea, and that means shortness of breath when you're lying down. They also will have the hypercapnia, and this is the increase in CO2 levels. They'll have the respiratory acidosis, and this is because of the hypercapnia. Okay, so as CO2 levels increase, that makes the body more acidic. Okay, so we see the respiratory acidosis. And then, do you see that picture? That's what we call a barrel chest. And usually for someone that has emphysema, they will develop this kind of barrel chest. And it's caused by the increased work of the diaphragm muscles over time. They kind of have this, yeah. The muscles are getting bigger, and some of the air is kind of trapped in the lungs, and so you kind of get this barreling of the chest. It looks like that volume pushes them out just a little bit, and that's kind of what creates that barrel-like shape. Part of it is overuse, and part of it can be that they're not fully exhaling everything all the time. And if you've seen anyone with emphysema, this is pretty prominent. Like you can tell that there's kind of like a barreling on the chest. Okay, so treatment, of course, smoking has to stop. Okay, so if they're smoking or they have a history of smoking, you want to help them with some sort of cessation program. Avoiding any air pollutants, because remember we said it could be caused by industrial pollutants as well. Exercise is usually as tolerated. Okay, and that's really going to be very individualized, and it may be quite limited. And nutrition should be overall good, but we'll talk about some of the specifics a little bit later.
So, how is it practical for the air pollution? I imagine your house is like control, but then you want to go outside.
I think more of it is like for the industrial air pollutants, so like people that maybe work certain jobs, not just like the overall air pollution. And then another thing you can do a lot of times, like some people who run outside, research looks at they should take higher levels of vitamin D just to counteract some of the oxidative stress they encounter. So maybe it means reducing the industrial pollutants if they're going to spend a lot of time outside exercising, making sure that they take additional antioxidant supplements. But you can't fully, like you said, remove the air pollution. You have to move from Houston, right? So some of the things you may see weight loss in these patients. Anorexia, which again is just the overall poor appetite. Lean body mass loss. That makes sense, right? You're losing weight, not eating well, you're losing lean body mass or muscle mass. The dyspnea, the fatigue, the bloating, and the bloating is related to the not fully exhaling all of the air. Early satiety, because if you can't breathe, you just don't have an appetite. Okay, you get full very quickly. Altered taste perceptions. You probably read my notes, but can anyone explain that to me? Why would someone have an altered taste perception? Could. What were you going to say? Yes. And what does that affect though? You guys are both right. Decreased saliva production is part of it. But when you breathe through your mouth, it also affects your taste buds. You guys ever had a sinus infection? Your nose all stopped up, you're breathing through your mouth. You tried to taste something that you like, does it taste the same? So that's another thing that further complicates it. They're breathing through their mouth. It don't taste the same. They have decreased saliva production and the taste perception changes. So what do we do for these patients? And I want to explain the calorie level here because it's relatively low, okay? It says 25 to 30 calories per kilogram. For patients that are on ventilator or some sort of breathing machine, we want to keep their calories relatively low. We usually stick to about 25. That's usually our maximum. Why do we go low for patients that are on the ventilator? That's part of it. They don't exercise, so they're not using a lot of calories, right? What's another reason we don't want to overfeed them on the ventilator? That's right. Eating increases the work of breathing. Metabolism, eating increases the work of breathing. So for these patients, we want to be very careful that we give them enough, but we don't overfeed them. Because if we overfeed them, we're putting more work on the lungs. And then do you think we're going to be able to take them off that ventilator if we're overfeeding them and putting more work on the lungs? No, it makes it harder. So in order to get them off the ventilator and to wean them back to breathing normally, we feed them just enough, but we don't want to overfeed them. So that's why for patients that are ventilated or on a breathing machine, we want to stay close to about 25 calories per kilogram. For patients that are not on a ventilator, we may do 30, or we may even go a little bit higher. Some patients that have COPD need greater than 30 calories per kilogram because their breathing is labored. And when you're working very hard to breathe, do you think that takes energy? It does. So some of the patients with COPD are able to maintain their weight and they don't have an issue. But others become very, very small and they lose a lot of weight. And for those patients, we do need to go higher than 30 calories per kilogram just because the work of breathing can increase their metabolic rate. So 25 to 30 is a nice base, it's a baseline, okay? But you really need to evaluate that for the patient that you're working with. If it's a patient on ventilator, you probably want to stay closer to 25 calories per kilogram. If you're a patient that's very thin and they're having difficulty maintaining their weight, you may go 30 to 35. So you kind of have to use this as a baseline and adjust it for the patient that you're working with. Does that make sense? So if I gave you that as a scenario on the test, you know what to do? Kind of? Hopefully. Okay. All right, so with protein, we're going to go a little bit higher than normal. We're going to go about 20% of total calories, which comes out to about 1.2 to 1.7 grams per kilogram. We do antioxidant supplementation, and that makes sense, right? Kind of talks about why antioxidants are so important in lung function. And then we do phosphate supplementation just because the respiratory muscles are often depleted in phosphorus when patients have COPD. So we supplement with additional phosphorus. We also supplement with calcium, and the rationale for this may be a little bit weird, but the risk factors for osteoporosis and the risk factors for COPD are related. So for instance, like smoking is a risk factor for both. So because patients have certain risk factors for COPD, they also may be at risk for developing osteoporosis. So we often give a calcium supplement as well. Okay, so as far as the NCP process, we're looking at some of the common things. You will see physically, they're looking at temporal wasting here. You guys know what temporal wasting is? That would be a wasting right here in this area. And that would indicate what? What could that be indicative of? We kind of saw like a wasting in the temporal region or hollow area. That would be the muscle, so that would show like body mass loss or muscle loss. So wasting in the temporal region may indicate that someone's experiencing some level of malnutrition. You'll see that they also, in the assessment portion, of course, they look at weight. They also look at like the arterial blood gases, so the amount of CO2 and O2 that's in the blood. There's nothing else really different up there. What about the diagnosis? Does anyone want to try writing a PDF statement with one of these? Want to try?
So involuntary weight loss related to chronic COPD as evidenced by increased respiratory rate.
What was the last part?
Increased respiratory rate.
Well, your thing was the weight loss. So give me something that would show weight loss. Just you can make up anything.
Labor breathing.
What if you said involuntary weight loss related to COPD? But we could get more specific. We could say related to anorexia as evidenced by 10-pound weight loss. Just remember the signs and symptoms has to go back to the problem. Make sense? Okay.
Where how when we have anorexia, can we use also face extension?
For what? For your etiology? So you said involuntary weight loss related to altered taste perception? Yes. It's evidenced by 10-pound weight loss or whatever. That's perfect. How do you guys feel with writing PES statements so far? Like on a scale of 1 to 5, with 5 being great and 1 being not so great, what do you guys feel? 4? 3? So I want to get a feel, because remember the next assessment I could ask you to write a PS statement on there, okay? So do you guys, should I give a little bit more practice with it? Alright, so maybe I'll do like a little writing practice thing for you guys to practice. Because you guys are super quiet, but I don't really know if you're getting it or not, but it's definitely, you are going to have to write one on the next assessment, so I do want you to feel comfortable with it. So I will do like a little writing, a little practice for you, but if you don't feel comfortable, then please come to me individually to let me know, okay?
So we know.
Right. Then it'll be easy, okay. Right. She said like when there's a case study, it would be a little bit easier, and that's probably it. So when we were doing the case study, I looked that up, and I think it was. I have to go back and look at it again. What, do you remember the question?
No, I just remember we spent a lot of time.
Yes.
And like somebody from over there and me and people from Seattle.
And then I found the answer to it. I found the answer to it, and then all this stuff happened, and then I forgot it. Right? Yes. So I will go back and look at the one we were talking about.
Yeah, and it would yeah, the issue was the etiology being the stroke. Like, should stroke be in the related to?
Are you sure was it the ketogenic diet was the etiology?
No, because I was on that was that said that stroke should be in the middle, and then we were.
Do you remember what the problem was though?
I mean, I think it was something like inadequate oral intake. I don't think it was like anything that the question.
I'll go back and look at that, pull up that PowerPoint, because when you guys were doing the case study, I looked it up and I had an answer for it. And then, so I'll go back and look at that. Yeah. Okay. All right. So, but these two are relatively simple, right? You can do the involuntary weight loss. You can do the inadequate oral intake related to early satiety, as evidenced by patient consuming less than 25% of meals. Okay. But we'll practice that a little bit more. I'll try to kill something by tomorrow. Huh? Less than 25% of meals. And again, if you had like a case study, that information would be given to you.
What's her etiology? The second one?
The next section, I think I have definitions. Just review those definitions there for the different types of mechanical ventilation. Just put a star by that to review those different types. We'll talk about cystic fibrosis. Okay? What do you guys know about cystic fibrosis? Know anyone with it or? Yeah, they typically usually die in mid-30s, but one time I had a student and her father actually had cystic fibrosis, so he lived a little bit longer than the expected, a lot longer than the expected age. She didn't say. She didn't say. It was a couple of semesters ago one of my students said her father had seen it. So, yeah, absolutely right. People are usually diagnosed at the age of 3, and the median survival age is usually like 37 or so. Okay, but probably now it's, increasing. We'll talk a little bit about the definition. So, cystic fibrosis is characterized by abnormally thick mucus secretions. We talked a lot about mucus this whole class, right? So again, abnormally thick mucus secretion in the epithelial of several organs. We'll specifically talk about how it affects the lungs and how it affects the pancreas. Okay? This is caused by a mutation of the cystic fibrosis transmembrane conductance regulator, or the CFTR. Okay? This is an autosomal recessive, so in order for a patient or person to develop cystic fibrosis, they must inherit the trait from both parents. This gene is responsible for transporting chloride ions across the membranes of cells, okay? And it does that in the lungs, the liver, the pancreas, the digestive tract, reproductive system, and skin. The major organs where we see issues with are in the lungs and in the pancreas. Because of a mutation in that gene, and the gene isn't able to transport these chloride ions, then it results in abnormally thick mucus secretions, okay? And these secretions often lead to obstructions of the glands and ducts in several organs, as I said, particularly the lungs and the pancreas. And so patients often end up developing pulmonary insufficiency, which can lead to pulmonary failure, which is what unfortunately can cause death in these patients. They also will have pancreatic insufficiency in majority, 85 to 90% of patients that have cystic fibrosis. And so when you're diagnosing it, there are a couple of different things that we can do. We can do is called the sweat chloride test. And with this test, what they'll do is usually induce some sort of physical activity on the patient, stimulating them to sweat. And they use like a special paper that absorbs the sweat and measures the amount of chloride that's in that sweat. So an increased amount of chloride would be indicative potentially of someone having cystic fibrosis. The pancreatic function test is also done just to measure pancreatic function. So to measure their ability to secrete the enzymes necessary for digestion. It will also do an x-ray and look at the pancreas overall to see if there's any sort of obstruction in it. And based on these two tests, then they'll determine if someone has cystic fibrosis or not. So I'm not going to go to the next slide yet. I'm going to let you guys think about this. So if someone has cystic fibrosis and there's an abnormally thick mucus secretion and it primarily affects the pancreas, what do you think we're going to see happen? Huh? Potentially. She thought I could potentially develop high blood sugar. Does that make sense? Yes. Yeah, it does. What else might you see? Issues with digestion, right? Because they can't secrete the enzymes that are necessary for digestion, right? So we see some of the same things we did with pancreatitis. In fact, didn't we say that CF could lead to chronic pancreatitis? Remember that? We said that CF was one of the causes of chronic pancreatitis because there's this mucus within the gland holding all those enzymes in there. If the enzymes are kept in there too long, they can activate prematurely and cause chronic pancreatitis. Huh? You're going to have the fat malabsorption. So for therapy, you're probably going to have to do what? What are you going to have to take? Enzymes. Okay? You guys already know this part. Okay, so pancreatic insufficiency, the poor digestion, poor absorption, loss of bile and bile salts, just like we talked about before. Pulmonary infections, because that mucus accumulates in the lungs as well. So they're going to have anorexia, poor appetite. They're going to have increased energy requirements because it takes so long for them to breathe, and because this is usually in children. Okay, and so we're also going to see malnutrition in this population. Okay, all of that makes sense. Okay. All right. So what do? We already said that they need pancreatic enzyme therapy. Okay, and then energy. It says adequate to support growth and development. Remember we said that they usually are diagnosed at 3, and a lot of, and their lifespan is reduced. So a lot of times when we're talking about CF, we're usually dealing with either very young children or teens. So we want to give them adequate nutrition to support their growth. We already know that they're at risk for being malnourished because of malabsorption. So when we're estimating their calorie needs, we we often kind of set a level, but we have to monitor it and maybe increase it in order to support adequate growth. A lot of times, these children are very small, and if you plot them on their growth chart, some may even have failure to thrive, just because they've had this long-standing history of malabsorption. So with energy, adequate to support growth and development. For protein, same thing. We can estimate about 15 to 20% of calories, but again, we want to make sure we adjust it to support their growth. And this last bullet point is a little bit different from what we did before, right? So normally when there's fat malabsorption, we lower fat content, and not for this population. We actually, it's a little bit higher than normal, right? It's 35 to 40%. Why? They're children. They're at risk for malnutrition, and that is the most caloric-dense macronutrient. So we give them enzymes, and we use more MCT if possible, but we actually increase their fat percentage.
You said that was for children, so once they become of age, does that go down?
Well, and I'll say for CF overall, it may go down some if you're talking about into adults, but definitely during like children and then adolescent, they're going to need the extra calories. And then we supplement with fat-soluble vitamins. All of that kind of is what we learned before, right? And then just knowing that, as she said, so with CF, that can turn into chronic pancreatitis. Chronic pancreatitis can develop into what? What kind of diabetes? Right? Type 1 diabetes eventually. So you see the progression? So you have CF, the glands in the mucus are holding those enzymes within the pancreas. They can't be released. So there's an increased risk of those enzymes becoming activated early. So then they develop pancreatitis. It's chronic because it's ongoing. And then eventually the pancreas stops functioning, and then they become type 1 diabetics.
So, regulation, at least small amount I know, it seems like the parents' lives are consumed by, like, I don't know what you call it, like, but like, it's got like all the breathing theories and stuff, so like, how does a family with children actually get by?
I love that you think about things like that. This is so important because we often, as professionals, think about, okay, this is what you should be doing. This is the diet that you should be following. But doing that is so much more difficult than just saying it, because in addition to that, they're receiving multiple sorts of medications. And another therapy that these patients get, they are patting their backs to loosen that mucus so that they can pump it out. You know, that's a constant part of the therapy that they're providing for these patients. Patting their backs, patting their chest, so they can loosen some of that mucus out so that it's not causing respiratory or pancreatic failure. Okay, so it is.
And to be fair, that
overall
yesterday was about little kids that have diabetes in the other class, and so they were talking about the parents now, like the apps. So it's not
Right.
where the parents can check it and like maintain and do all the little therapy for the children if they're willing. I understand.
But when you have a child that has some sort of chronic disease, it affects the entire family, and oftentimes at least one or both parents are unable to work because it's just all inside. As I mentioned, I think the last time we had class, I told you about one of my really good friends whose daughter has the epilepsy. She can't work because that's a constant, part of her routine. So when we're thinking about these chronic diseases and how they affect children, you have to remember that they begin to affect the entire family. And oftentimes, at least one of the parents are unable to work because that child does need the constant care. So when we're thinking about what sort of therapy we're recommending for them, we have to be aware of costs. We have to think of this mental and financial impact that all of these things will have on the patient and the family. Okay, it's not just here, take pancreatic enzymes, here, eat this. You have to think about the financial constraints or restraints that family may have. Big part of it. So this is just the NCP part. Kind of a little part of it got caught up, I'm not sure why.
The next one.
Oh. Okay, all right. So let's look at potential diagnosis. Anyone want to just kind of reach out there and try one? That is written on the paper. It's rarely used. Yeah, it's usually used more if someone's on a very limited diet or if they're usually a limited diet. Or it could be like financial issues as well, but rarely used. Most common ones would probably be the inadequate energy intake. And that could be related to, for this patient, anorexia. Some of the typical things that we use as evidenced by, you could do patient's weight loss, or you could do consuming less than recommended calories, something of that nature referred to this one. You could do the involuntary weight loss as well. That could be related to the anorexia, or it could be related to malabsorption for these patients.
Previous she said her grandpa can't even eat coffee. So it's her version is like similar where like as you're sitting down to eat, like you just can't get that right all the time.
Yeah. Christine's question was, does the coffee, would that impact their ability to eat as well? So just like we see with some of the other pulmonary conditions like COPD and asthma, if a person is having the increased coffee and the increased mucus, that's going to affect their ability to eat also.
If you're doing your PS statement based off of like a dietary recall, could the sign and symptom be like a certain percentage of their macronutrient?
Yes.
Like, okay.
So she said if you're doing your PS statement based on like a dietary recall, maybe you analyze their diet and you could say patient consuming less than 30% of calories per pound or something like that.
Okay.
Yes. As long as you have that information done.
Okay.
And then under the intervention, you'll just see that there's increased nutrient needs. We've kind of touched on that, and maybe some sort of oral nutrition supplement. So something between meals to kind of increase their intake, as well as probably with these patients, maybe small feedings throughout the day also, because they get full very quickly. They may have coughing episodes, so small frequent meals also.
That's a Carol.
Sorry.
What is the feedback actually for nutritional quality of life? Like what is that?
That is either, it's not commonly used problem, but it would either refer to someone having a very limited, like a restricted diet, or someone with certain financial restraints that affected their intake.
Okay, so it wouldn't be like related to poor digestion. It would be
Could be. Could be. Yeah, so you could say maybe poor nutrition, quality of life related to malabsorption, as evidenced by,
early fatty stools.
yeah, I was thinking steatorrhea.
Okay.
And steatorrhea could be evidence of poor nutrition, quality of life. Yeah, technically. Yeah. Good thoughts.
Early satiety or fatigue is related to inadequate energy.
Yeah, so you can say inadequate energy intake related to early satiety. inflammation in the lungs caused by some sort of bacteria, virus, fungi, and it can also be caused by gastric contents, which we'll talk about. There are two main types, but we're really going to go over three types today. There's the community-acquired pneumonia and the hospital-acquired pneumonia. Community-acquired pneumonia is just kind of what you get out in the public, when it's kind of the fall season, everyone seems to get sick, you touch something, germs are spread out in the community. You also have what's called hospital-acquired pneumonia, and this typically occurs in the ICU, and it's often spread between patients because, number one, they're on a ventilator, and it's not that the germs are in the ventilator, but when you're on the ventilator, you're usually laying down, you're not moving, and you're unable to clear your lungs or to clear the bacteria out of your lungs. So because you're in a still position and because you're not really breathing for yourself, you're at an increased risk for foreign materials to settle inside your lungs. It's not that the bad things are in the vents, they clean the vents. It's just that because you're not able to clear your secretions or clear your lungs, they're at an increased risk for developing pneumonia. We also know that, and if I have any of my nursing students in here, we also know that nursing is a really awesome job at clearing secretions for patients. When patients are on the ventilator, they have to go and suction out their mouth, clean their mouth, so that they can reduce the risk of them developing pneumonia. But nothing's perfect, right? So if I'm an ICU nurse and I have 3 patients, and I go in there, wash my hands, do my first patient, I come to my next patient, maybe I don't use the greatest hand hygiene, and now I'm clearing out secretions from patient B, right? So potentially, it shouldn't happen, but potentially people can pass things by not practicing good hand hygiene as they're doing that. And then also, as I said, because people can't clear secretions on their own, patients in the ICU, patients on ventilators, have an increased risk of developing hospital-acquired pneumonia. Okay, I just want to make clear because sometimes when I say it, people think that the bacteria and the fungi are in the ventilators. They're not in the machines themselves. It's just that the patients can't clear their own secretions. And sometimes, unfortunately, because nursing is dealing with so many patients, things can unintentionally be spread. Okay? Third type. So those are the two main types, but I'm going to kind of tag on a third type that I want you to know about. And this one is aspiration pneumonia. Okay? So we see aspiration pneumonia in people that have had strokes. We see them in patients that are on tube feeding. Because what happens is, number one, if you had a stroke and you're not able to swallow, and you can't really control the food in your mouth, it can accidentally go into the trachea, get into the lungs, and settle there. And because that's foreign, it shouldn't be there, it causes an infection. Okay, so we aspirate on food or gastric contents, which get into the lungs below the vocal cord, they sit there and they cause an infection. Patients that are on tube feeding usually goes through the mouth and into the GI tract, right? Into the esophagus, into the GI tract. So all of those, I can't think of words today. What are those things that close? I can't think of words. The valves, kind of like the valves, right? All the valves are open because you got the tube going down them, right? So if all of that is open, it's very likely that some of that could come back up and get into the lung. So for patients that are on tube feeding, because they're kind of like laying down and everything is open, that food or the gastric contents can come back up and aspirate into the lungs. So patients with chewing or swallowing problems and patients that are on tube feeding are both at risk of developing aspiration pneumonia.
Can you repeat the last part?
Yes. So patients that have issues with chewing and swallowing and patients that are on tube feeding are at risk for developing aspiration pneumonia.
They're laying down. Is there it possible to incline some of these?
Yes. Perfect. That's exactly what you should do. So typically what should happen if a patient is on tube feeding, the head of the bed should be elevated to about 45 degrees so that they're not laying flat. And that helps reduce some of the aspiration. Very good.
I know because my dog has my esophagus. And so when they tell us to, when she eats, to try and have her not lay down or just kind of stand still. So
Exactly.
esophagus will.
Gravity will pull it
Yeah.
down, right? Exactly. So same concept. We like to keep the head of the bed elevated to about 45-degree angle or so. So it just kind of keeps that food down so they don't aspirate. Okay. And respiratory failure, there's not a lot on this. The only thing I want you to understand is that respiratory failure, when an organ fails, that implies that something else needs to take the place of that organ. So when a patient is experiencing respiratory failure, then they're usually on the vent and they're unable to get off of it. So it kind of progresses. So if you have a pulmonary condition, you have respiratory insufficiency, where the respiratory system needs help, and then you progress to respiratory failure, where the system overall fails. At that point, when an organ or a system is experiencing failure, that implies that an outside machine or an outside source needs to replace that function. So when someone has respiratory failure, they're typically on the ventilator, and that is usually an ongoing issue, unfortunately, until they make a decision on what to do with that. Okay, but respiratory failure can occur from any of the diseases that we talked about. COPD can lead to respiratory failure if not treated long term. Probably not so much asthma, but COPD and cystic fibrosis can ultimately lead to respiratory failure. I know there's some notes on there. We're not going to go too much into that. When we talk about our section on metabolic stress, we'll talk about how to treat these patients nutritionally when they're experiencing respiratory failure. For the scope of this lecture, I just want you to understand that some of these conditions, if progressed or not treated, can lead to respiratory failure.
I have a question about COPD. So in like major cities that are, have like a higher air pollution, are there any statistics that require like more cases of COPD in those, or is air pollution alone like not significant?
I don't know. I would have to look at that. But I would think that, of course, it may have a minimal impact, but I just think that smoking and the secondhand smoke are going to be a much more important risk factor than just the general air pollution. Now, I would say that because things are very individualized, there are probably people that are more prone to developing COPD, so it doesn't take as much exposure. Do you know what I mean? But I definitely think that the smoking, secondhand smoke, and the industrial pollutants are probably going to be the highest risk factors. Like work environment. Yeah. Other questions? But that would be an interesting statistic to look
Yeah, and
at.
I wonder if that were the case, and maybe not like Houston is bad, but there's cities that are worse.
That are worse.
Maybe,
Right.
and if it would be possible to do like longitudinal studies that can correlate the antioxidant to like the outcome.
And the issue with the antioxidants is just because getting a longitudinal study long enough to see the ongoing effects of it, ensuring that people are taking
controlling all the
antioxidants, controlling all of those factors makes it so difficult to actually prove. In theory, it works, but haven't been able to prove it yet.
For I think the lecture, and I mentioned on the slides, a lot of like notes version, but just vitamin E. So for respiratory conditions, is vitamin E like something appropriate? Because for lung cancer, it's been studied multi-degree due to like excessive testing treatment. So like,
Vitamin E is controversial. Again, it was included in here because it was an antioxidant, and that was before the more recent studies that say. excess or
It's probably
additional
something
vitamin C
that you ate that's
has
not there for
contraindications.
Like for an amount or some other factor that they can pull out and say like, you know, of these like higher infection numbers, like say that the subgroup of people with X with other treatments.
And they haven't been able to do that, right?
It doesn't seem like it, and I can't tell like
Yeah. I think I looked at it probably almost a year ago.
I have a test to study for. You need to let me go. I have a test to study for. You need to let me go.
More probes, benefit from it or anything like that.
You haven't went to the already?
But
Okay.
no, for now.
Mine's at 4, so.
Other questions? Okay. You guys want to ready to take your LAQ real quick?